Good morning, everyone. My name is Dr. Craig Gluckman. I'm a clinical instructor of medicine and a gastroenterologist in the Division of Digestive Disease at UCLA. Thank you for joining me this morning on my webinar. I'm very excited that you've taken the time out of your busy mornings to join me. And this is a topic that's near and dear to my heart. The topic of the talk is trouble swallowing and evaluation and treatment of dysphagia. During this talk, if you have any questions or comments, please reach out to us on social networks, social media. Either use Twitter or contact us on YouTube. So let's dive right in. Before I can start my talk on dysphagia, I need to explain exactly what dysphagia is. Once you know what dysphagia is, then I can tell you exactly what causes dysphagia. Should we worry about dysphagia? You know, the mere fact that we're having this webinar this morning suggests that yes, we should worry about all causes of dysphagia. Then I will talk about how dysphagia is diagnosed, and finally I'll go through some of the management of various causes of dysphagia. So in terms of the definition and what exactly dysphagia is, it's very helpful to look at the word dysphagia, and you can see it originates from two parts. The first part is the English dys, dys, which means difficulty or disordered. And the second part is phagia, which is the Greek meaning eating or to eat. So if you put it together, dysphagia is disordered or difficulty eating. It's very different from odonophagia, which is painful eating. And for the purpose of this talk, I'm really going to concentrate on dysphagia and perhaps leave odonophagia for another webinar at another time. So the patient comes to a gastroenterologist's office, they report trouble swallowing, and the gastroenterologist might say, you have dysphagia. And there are a lot of thoughts that could be going through the patient's mind. They might be worried, they might be scared. Is it a problem with swallowing? Is there a problem with their esophagus? Is there a problem with their stomach? Could it be cancer? Could it be acid reflux? Will they need more tests? Will they need an endoscopy? And for the duration of this talk, I really want to kind of relieve some of the worrying thoughts that might be going through any patient's mind as they present with troubled swallowing. So we as gastroenterologists, we really like to simplify things as much as possible, and we simplify dysphagia into two main big causes. The first cause of dysphagia is what we call oropharyngeal dysphagia. And this is any problem in the oro, which is the mouth, or pharynx, which is the back of the throat. And if you look at all the organs that make up the oropharynx, you can see it's a pretty complicated mechanism that controls our swallowing. And it's important to note that anything that affects the nerve or muscles controlling any of these organs could result in a patient having oropharyngeal dysphagia. You'll note that the esophagus, and really only the proximal, the very top part of the esophagus, can become an issue in patients with oropharyngeal dysphagia. And the majority of these organs are really the domain of ENT doctors or neurologists. So we'll often see a patient, we'll make the diagnosis of oropharyngeal dysphagia, and we'll often refer the patients on to an ENT or neurologist to co-manage the patient. The next main group of dysphagia is what we call esophageal dysphagia. And we know that the esophagus is this narrow tube that connects the mouth to the stomach and allows food and liquids to go down from the mouth into the stomach. So anything that can cause a blockage or a narrowing or an obstruction in the esophagus can result in esophageal dysphagia. At the top, I've highlighted a medical history, and every time we see a patient, a medical history is vitally important, but especially in a patient with dysphagia, if you can really spend that extra 2 or 3 minutes in really asking what the patient means when they talk about trouble swallowing, that can go a long way in determining which kind of dysphagia we are dealing with and what's the next test and investigation that we need to do. So I'm going to start off by going through oropharyngeal dysphagia. We also sometimes refer this kind of dysphagia as transfer dysphagia because patients have an issue or a difficulty in transferring food from their mouth into the esophagus. So another term that you might hear is transfer dysphagia. So what are some of the questions that I would ask any patient who I suspect has oropharyngeal dysphagia? And the first question I would ask is, does the patient have difficulty initiating a swallow, or is the problem within the first few seconds of swallowing? So you take a bite of food, you drink a sip of water, really within that first few seconds you have an issue. I'm more suspecting oropharyngeal dysphagia. And what could some of the issues that you have, what could it be? You might have coughing, you may have choking, there may even be nasal regurgitation, which is where liquids, can almost come out the nose, and some patients could even report that they might have drooling. Patients will often say that liquids give them more of a problem than solids. We know that liquids are more fluid and they tend to flow into places that we don't want them to go. So patients will often report that they have much worse issues with liquids than solids. Patients will often say that food or even pills can remain, at the back of the throat even a few seconds after swallowing, and this is often a telltale sign of oropharyngeal dysphagia. Patients may have been in hospital with aspiration, and later on in this talk I'm going to go into much more detail about aspiration, but basically that's when food or liquid goes down the windpipe or the trachea, which is really where we don't want it to go, and that can lead to an aspiration pneumonia. Patients can be very sick and even land up in hospital. And lastly, because I mentioned that neurological issues affecting the throat and the back of the mouth, it's really important for me to know if a patient has any neurological issues, and that's a really important question I'd ask in the history. So we can see that the mechanism of swallowing is pretty complicated, but I'm going to try to simplify swallowing in these next three pictures. So if you look at picture number 1, you can see that there's the bolus of food on the tongue, almost in the back of the throat, and you can see everything is nice and open. Air is able to flow down the soft palate. It's able to flow through an open epiglottis into the trachea or windpipe, excuse me. And something important that you can also see is that the upper esophageal sphincter, which is a valve or kind of a gateway at the top of the esophagus, that is closed just before we're about to take our swallow. Moving on to picture number 2, 3 important things need to happen. Number 1, the soft palate needs to close, and that's to prevent liquids from regurgitating up into the nose. The epiglottis needs to close, and that's to prevent solid food or liquids from moving down into the trachea or windpipe. And finally, that upper esophageal sphincter needs to open to allow the bolus of food to move smoothly down into the esophagus where we want it to go. And then in the final picture, you can kind of see everything kind of reverses. So the soft palate opens, air is able to move through the soft palate, through the nose, down the windpipe into the trachea. And something important that has to happen is the upper esophageal sphincter has to close to prevent food from regurgitating up into the mouth. So you can see that the swallowing pathway is a really complicated mechanism, and any issue anywhere along that pathway can result in oropharyngeal dysphagia. So what are some of the main causes of oropharyngeal dysphagia? And this table is by no means comprehensive, but I tried to divide it into 2 of the main groups. The first group is neuromuscular, and that's any issue with the nerves or muscles that control our swallowing pathway. Things like strokes, Parkinson's disease, severe dementia, motor neuron disease. Many patients with these conditions can present with signs and symptoms of oropharyngeal dysphagia. Certain brain tumors, especially if they've affected the swallowing center, can result in oropharyngeal dysphagia. And because I mentioned that anything affecting the nerve or the muscle controlling the swallowing reflex can be involved, all these conditions, things like neurological infections, muscular dystrophies, myasthenia gravis, polymyositis, all these conditions that affect the nerves and the muscles involved in swallowing can result in oropharyngeal dysphagia. Moving on to the second main group of causes, we have structural issues. So a patient with severe pharyngitis or a patient who's had radiation and suffered radiation injury, you can imagine that if there's irritation or inflammation at the back of the throat, this patient is not going to be able to swallow. Anything that presses on the esophagus from the outside, and things that could press on the esophagus are cervical osteophytes, which are kind of bony spurs that we see in patients with osteoarthritis. These sometimes press on the esophagus and result in dysphagia. Also, a very large thyroid gland. If that presses on the esophagus, that can give the patient difficulty in swallowing. I showed you earlier on how important a palate is in the swallowing pathway, and any patient with a cleft palate, this will allow food or liquids to regurgitate up and out through the nose, and this is an important cause of oropharyngeal dysphagia. Any oropharyngeal cancer, things like cancers of the throat, the back of the mouth, the base of the tongue, these could all interfere with swallowing and lead to oropharyngeal dysphagia. And these last two causes that I've listed here under structural causes are cricopharyngeal bars and webs and zenka diverticulum. A bar or a web is a narrowing that occurs in the very top part of the esophagus that can interfere with swallowing. And a zenka diverticulum is a little pouch that can form in the top part of the esophagus and interfere with swallowing. But as you can see, most of the causes that I've listed on this table are really in the domain of an ear, nose, and throat doctor or a neurologist. And we as gastroenterologists would see a patient with dysphagia, we would suspect oropharyngeal dysphagia, and we would really refer on to a colleague, for the co-management and really a multidisciplinary approach to managing these kind of patients. So what is the first and most important test that I would do on any patient who I'm suspecting oropharyngeal dysphagia? And the test is a modified barium swallow. And as you can see, this patient is undergoing a modified barium swallow. There are two very important other people in the room. We have our friendly speech and swallow therapist, and we have our radiologist or radiographer who will all assist the patient during the modified barium swallow. And what the modified barium swallow involves is the patient will actually drink barium, and the barium is able to go through the top part of the mouth, and we can actually see in real time where the specific problem is with swallowing and which specific organ is maybe affected, causing this initial oropharyngeal dysphagia. We do this by looking at a fluoroscopy screen, which allows us to look at an X-ray, but it's almost like a movie, so we can actually see in real time how the patient is swallowing and where the problem may be. The reason a modified barium swallow is so important is because we want to know if the patient is an aspiration risk. And what we mean by an aspiration risk is food or liquid going where we don't want it to go? Is it going down the windpipe or the trachea? We obviously want food and liquids to go down into the esophagus, but in patients who do have oropharyngeal dysphagia, sometimes food can go, so-called down the wrong pipe, and this patient would be termed an aspiration risk. Anyone who is an aspiration risk, swallowing food or liquids may actually be dangerous because, as I said, if food goes down the wrong pipe, the patient may aspirate, develop an aspiration pneumonia, and land up in hospital. So what is the management of oropharyngeal dysphagia? First of all, it depends on the cause. So if you have an infection, we need to give you antibiotics to treat the infection. If you have some sort of cancer in the oropharyngeal area, we'll refer you to an oncologist. But in the meantime, what can we as gastroenterologists do to help a patient with oropharyngeal dysphagia? And a really important person is our friendly speech and swallow therapist, because they can give maneuvers that can help a patient swallow. A very common maneuver is the chin tuck, where the patient will literally tuck their chin forward. And this may be all that is needed to really help a patient to swallow. And this is a useful thing that they can do at home and allow them to swallow some liquids and solids. The speech and swallow therapist might also recommend certain changes in their diet. For example, we know that thickened liquids may be more easy to swallow than thin liquids. So while we're treating the cause of oropharyngeal dysphagia, in the meantime, the speech and swallow therapist can help with some simple lifestyle and dietary modifications. But what happens if the patient has really severe oropharyngeal dysphagia? They're an aspiration risk. Every time they swallow solids or liquids, it might spill down into their trachea. They might aspirate. They can start coughing. These patients are aspiration risks, and really we would encourage them to be nil by mouth. They shouldn't have anything by mouth in terms of liquids or solids. So what can we do? Patients need to eat. They need hydration. They need to take medications. They need foods. Otherwise, they're going to become malnourished. So what can we do for these patients? And really what we want to do is we want to bypass this area, and we want to be able to get foods and liquids directly into the stomach. And how we are able to do this is a procedure called a feeding tube. It's not a major surgical procedure. It's done using an upper endoscope where we make a small incision into the skin and we're allowed to place a small feeding tube directly into the stomach. This will allow us to bypass this area, which is the issue causing oropharyngeal dysphagia, and we're allowed to provide food, liquids, medications directly into the stomach while a person's oropharyngeal dysphagia is being managed or treated. I would like to mention two very important issues and concerns with feeding tubes. Number one, once a patient gets a feeding tube, by no means does that mean they always have to have a feeding tube. And what I mean by that is if in 3 or 6 months, whatever's causing the oropharyngeal dysphagia gets better, we can easily remove the feeding tube, the hole in the skin can close up, and the patient can go back to eating normally. So that's the first point. The second important point about feeding tubes is that we used to really only insert these kind of standard long tubes. They were maybe cosmetically unappealing. Patients could maybe pull them out by mistake. They could dislodge. But nowadays, we as gastroenterologists are able to insert these low-profile feeding tubes. They sit nice and close to the skin. They're more cosmetically appealing. You can wear a tight T-shirt without anyone knowing. They don't dislodge. They're more difficult to pull out. And I'd really encourage any patient, or if you know anybody who has the old standard feeding tube, please do discuss with your gastroenterologist to see whether they'd been a candidate for an insertion of a newer low-profile feeding tube. So I've said a lot about oropharyngeal dysphagia. Now I'm going to move on to the next main broad category, which we call esophageal dysphagia. And remember, the esophagus is the tube that connects the mouth to the stomach. And these are the questions I'd ask any patient who I suspect esophageal dysphagia. First question I'd ask is, does the food get stuck many seconds after swallowing? And we can contrast that with the patient with oropharyngeal dysphagia where the food gets stuck or there's an issue right away. Patients with esophageal dysphagia report that solids may only be the issue, or solids more than liquids may be the issue, or both solids and liquids are the issue. And you can contrast this with a patient with oropharyngeal dysphagia where really they have a problem with liquids. I'd like to know, are the symptoms intermittent? And by intermittent, I mean maybe they can eat breakfast today and food goes down, no problem. They have lunch a little bit later and something gets stuck. So the symptom is kind of coming and going. That's important for me to know. Is the symptom of dysphagia rapidly progressive? And by that I mean 3 weeks ago they could swallow perfectly, and now today they've got issues. So whatever's going on seems to be progressing rapidly. I'd always ask a patient where they think the food might be getting stuck. And even though this might be unreliable, it's still important to ask. So sometimes I'll say to the patient, where do you think food gets stuck? And they'll point higher up. And meanwhile, the problem is lower down, and vice versa. They could point lower down and say the food gets stuck lower down, but oftentimes the issue is higher up. So I still always ask this question, even though it's sometimes unreliable. It's important to ask for any other symptoms, things like weight loss, heartburn, and chest pain. Does the patient have any other medical or surgical problems that might be explaining their esophageal dysphagia? And lastly, I'd like to know, is the patient taking any medications? And especially in this day and age where a lot of our patients are on opioid medications, we know that opioid medications can result in motility issues of the esophagus, and patients can sometimes present with swallowing issues. So what are the main causes of esophageal dysphagia? And I've broken them down into the main causes, and by no means is this list comprehensive, but this really highlights the main causes of esophageal dysphagia. So at the top, I mentioned structural abnormalities and anything affecting the structure of the esophagus. So could there be a web or a ring at the top or at the bottom of the esophagus that's impeding the flow of food or solid or liquids from going down the esophagus? Could the patient have a tumor, maybe benign or malignant, that's blocking the esophagus? And could there be some sort of stricture? And a common type of stricture that we can diagnose is a peptic stricture. We often see this in patients with acid reflux. But just to mention, now that we are able to treat our patients with acid reflux so much better with newer proton pump inhibitor medications, we as gastroenterologists are really finding that we're not seeing peptic strictures as commonly as we used to. The next main cause of esophageal dysphagia is anything that can cause infection or inflammation of the esophagus. And the first point that I've mentioned is something called pill esophagitis. And what that means is certain medications can cause irritation or inflammation of the esophagus. It's often painful, so this is a cause of painful swallowing or dynophagia. This is why we always tell our patients to drink their tablets or medications with a big glass of water and to wait about 30 minutes before lying down after drinking those tablets. Any infection of the esophagus may result in esophageal dysphagia. Erosive esophagitis, which we see as a result of acid reflux, can cause inflammation of the esophagus and can lead to dysphagia. And this is the kind of new kid on the block. We call it eosinophilic esophagitis, and I'm going to go into much more detail about eosinophilic esophagitis later on in my talk. Another main group of causes of esophageal dysphagia is extrinsic compression. Remember, the esophagus is a hollow tube, so anything that presses on the esophagus, like lymph nodes in the chest, a big heart, a big thyroid gland, this could result in the impedance of solids or liquids down the esophagus and result in esophageal dysphagia. There are many motility disorders, and motility disorders is basically where the function of the esophagus, how the esophagus actually pushes the liquids or solids down the esophagus, are affected in various motility disorders. And a common disorder that you may have heard is achalasia, esophageal spasm, jackhammer's esophagus, or even scleroderma. At the bottom of this list, I've mentioned functional, and functional is when we've gone through all the causes of esophageal dysphagia and yet we don't have a cause, but yet the patient still complains of dysphagia, difficulty in swallowing. Thankfully, this condition is very rare, I'd say about less than 5%. But just to know, once, and sometimes we do all the entire workup and we don't find a cause of the dysphagia, we therefore refer to that as functional dysphagia. So in terms of the evaluation of esophageal dysphagia, these are the various tests that a gastroenterologist may need to do. And you can see at the bottom, I've said a combination of the above, because I don't want you to think that if you go to a gastroenterologist, you'll get one test and, we're done. We might need to do 1, 2, 3, or sometimes all 4 of the tests I've listed to really get the diagnosis, because there's no perfect test, and we use a lot of these tests in a complementary fashion. So don't be surprised if you do have esophageal dysphagia, your gastroenterologist may want you to have multiple tests so we can pinpoint the diagnosis. The first test that I would do for a patient with esophageal dysphagia is an upper endoscopy, also known as an EGD or esophago-gastroduodenoscopy. This is a thin tube, it's a flexible tube, it has a light and a camera at the end, and we're able to place it down the mouth, it goes down the esophagus and into the stomach. The patient is generally lying on their side, and we always do this procedure under sedation, so it's not uncomfortable in any way. And one of the advantages of an upper endoscopy is not only can it diagnose esophageal dysphagia, but we can also use it to treat many causes of esophageal dysphagia. So this is an upper endoscope, and this is showing a normal esophagus. As you can see, it's a hollow, narrow tube. It's pink in color, and you can see food and liquids would really be able to go very easily down this normal esophagus. Compare it with these 4 images, you can really see that this patient, these different patients, would present with esophageal dysphagia, and you can see food and debris, you can see a narrowing, you can see inflammation and even fibrosis. So it's easy to see why these patients would have esophageal dysphagia, whereas this normal endoscopy, the patient would have no problem and food would be able to go into the stomach without an issue. One important condition that we can diagnose using an upper endoscope, and at the same time we can actually treat this condition, is a peptic stricture. And what a peptic stricture is, it's narrowing of the esophagus, and we see this narrowing secondary to acid reflux. And as I said previously, because we're able to treat acid reflux with newer medications like proton pump inhibitors, peptic strictures are much less common, but if we do see them, we're able to treat them. So this is an upper endoscopy of a patient with a peptic stricture, and you can see how narrow this esophagus is. You could almost imagine that if a patient were to have some chicken or meat or a sandwich, it may really get stuck at this point, but liquids would probably be able to flow down easily with no problem. And how can we treat a peptic stricture? So at the time of an endoscope, we pass a catheter down the endoscope, and at the end, the catheter has a balloon. And here you can see the balloon being inflated, and we can inflate the balloon to different diameters. Here you can see the balloon inflated. And as the balloon inflated, it stretches the stricture and results in much relief of the narrowing of the esophagus. And patients who come in with a complaint of esophageal dysphagia from a peptic stricture, almost immediately after we've done an endoscopy with stricture dilation, the patient might report that their swallowing is so much better. So it's very rewarding that we can not only diagnose peptic strictures, but treat them at the same time as doing the endoscopy. Another condition that we can diagnose using an upper endoscope is eosinophilic esophagitis. And because the term is quite a mouthful, we normally refer to it as EOE. And basically, I said esophagitis is any condition that causes inflammation or irritation of the esophagus. And we know in EOE patients, the irritation results in an excess of eosinophils. And eosinophils are basically white blood cells that we see in patients with eosinophilic esophagitis. This is an upper endoscope of a patient with EOE, and you can see how narrowed this esophagus is. It's scarred, it's ringed, so clearly this patient would have a problem with swallowing. We often refer to EOE as asthma of the esophagus because, as I said, we think it's due to a possible food allergy, and similar to asthma, where patients get narrowing in their airways, patients with EOE get narrowing of their esophagus. We find that EOE is a relatively new disease, and by that I mean in the last 15 or 20 years we're seeing a much more higher incidence of EOE. We think that's due to the food allergy that I spoke to above. It often presents in young white males, but not always. I've diagnosed many older males, many older females, even children with EOE, but generally young white males. Patients tend to have the allergic phenotype, which means they may have associated asthma, eczema, allergic rhinitis, so this is often a clue that we might be dealing with EOE. And how do the patients present? Is they present with food impactions, which means that solid food can literally get stuck in the narrowed esophagus, and the food gets stuck because the esophagus is strictured. So this is the upper endoscope of different patients with EOE, and you've seen enough upper endoscopes of different esophaguses to know that these patients would have problems with swallowing solid food. You can see this esophagus is ringed, there are furrows, there are exudates, and in this picture you can even see that a solid bolus of maybe chicken has gotten stuck in this esophagus. So why is it important to treat EOE? Obviously we want to decrease the chance that solid food impaction can happen, and we want to decrease fibrosis. And what fibrosis means is that the esophagus gets scarred, and the scarring leads to narrowing. So it's very important if a patient is diagnosed with EOE that we give them medication to decrease this fibrosis. What are some of the treatment modalities for a patient with EOE? We often start with proton pump inhibitors. These are similar medicines that we use to treat acid reflux, and they're often very successful in treating EOE. If proton pump inhibitors don't work, we can try topical steroids, and that's either steroids that we breathe in and swallow, or liquid suspensions of steroids that we actually swallow because we want that to coat the esophagus. If PPIs or steroids don't work, we often will try elimination diets where we eliminate certain food groups, and then we reintroduce foods one at a time, and oftentimes we can find which culprit is triggering the allergic reaction that we think is causing the EOE. And lastly, if we have to and we see strictures, we are able to dilate the esophagus of a patient with EOE. The second test that we use in any patient with dysphagia is a Barium Swallow, or also known as an esophogram. This is different to the modified Barium Swallow that we did on patients that we suspected oropharyngeal dysphagia, because this type of esophogram actually looks at the esophagus. So once again, the patient is in a room with a radiographer. We look at the screen under fluoroscopy, and the patient is given barium to drink, and in real time we can actually watch the barium as it moves down the esophagus. So these are 3 different patients all who've had barium swallows, and I'm showing 3 different causes of esophageal dysphagia. This first patient, you can clearly see, has a narrowing of his esophagus, and it's not hard to see that if the patient were to have solid food, this stricture would result in esophageal dysphagia. This is another patient who also presents with esophageal dysphagia. You can see there's a narrowing or a ring at the bottom, and once again, you could see how solid food would not be able to get through this point. And finally, these 2 patients, unfortunately, were diagnosed with esophageal cancer, and you can see that this esophagus is really narrowed. It doesn't look abnormal. We talk about a so-called apple core appearance, and clearly this patient would present with esophageal dysphagia. I would never use a barium swallow primarily to diagnose esophageal cancer. This patient clearly needs an upper endoscope with biopsies. They'd need a CAT scan, and they'd need to be seen by an oncologist. Another test that we can use to diagnose patients with esophageal dysphagia is a high-resolution esophageal manometry. We like to call this esophageal manometry for short. And what esophageal manometry is it's a very thin catheter with sensors all along the catheter. And we're able to place this catheter down the patient's nose. It goes through the esophagus into the stomach. And as you can see in this image, the thin catheter is going down the nose, down the esophagus, and into the stomach. And what are some of the reasons and the advantages of doing high-resolution esophageal manometry? Number 1, it's an outpatient procedure, so the patient can come in. We can do it in the office. We can do it in the endoscopy lab. Unlike an endoscopy, no sedation or monitoring is required, so the patient can go home immediately once the test has been done. Generally speaking, esophageal manometry is well tolerated by most patients. It's very useful in diagnosing esophageal motility disorders. And what I mean by motility disorders is where the esophagus is maybe not pushing food or liquids properly through the esophagus. We use manometry to evaluate the sphincters as well as the function of the esophageal body. And we have 2 sphincters. We have a sphincter at the top and a sphincter at the bottom, and I'm going to show you a bit more detail in the slide to follow. And lastly, esophageal manometry is very important to evaluate esophageal dysphagia, especially if the endoscopy is normal. So this is a picture, and we get these beautiful tracings by using the esophageal manometry. And without going into too much detail, this is the upper esophageal sphincter. This is the lower esophageal sphincter. This is the bolus of food moving down the esophageal body. And I can tell you that this is a normal esophageal manometry. I like to refer to manometry as almost like the EKG of the esophagus because it really tells us about the function of the esophagus. So one important condition that we can diagnose using high-resolution esophageal manometry is achalasia. And what achalasia is it's destruction of the nerves in the esophagus. And the patient could present with dysphagia to both solids or liquids. They may have regurgitation of foods. There might be chest pain. There might be weight loss. And 2 important things happen in the esophagus of a patient with achalasia. First of all, the esophagus dilates. And here you can see in this barium swallow, a very dilated esophagus. And the second issue is that the lower esophageal sphincter, that valve at the bottom of the esophagus just before it goes into the stomach, doesn't relax, which means it doesn't open. So once again, on this barium swallow, you can see the barium is kind of getting caught up in this very dilated esophagus. There is narrowing at the end of the esophagus. And this is how a patient with esophageal dysphagia due to achalasia would present. These are esophageal manometry of the various subtypes of achalasia. And why subtyping achalasia is important is because it determines what treatment. So based on the various subtypes of achalasia, that will determine what treatment. We can start off with pneumatic dilation. And pneumatic dilation is we use a very large balloon, much larger than the balloon we do for esophageal strictures. Because when we dilate achalasia, we want to use large amount of pressure to really stretch the muscle. Another mode of treatment of achalasia is a laparoscopic helomyotomy. And often we do this with a fundoplication. This surgery, is normally done by a surgeon. It's often done laparoscopically. And the surgeon will actually cut the lower esophageal sphincter, which is the muscle at the bottom, and that will relieve the dysphagia. At the same time, he'll do a fundoplication, which is an acid reflux procedure to prevent acid reflux after the surgery. The third way we could treat achalasia is the new kid on the block. We call that per-oral endoscopic myotomy, or POEM for short. And this is done by a gastroenterologist. It's done endoscopically, where the gastroenterologist will actually cut the muscle from the inside. It's a day procedure. It's very successful. Patients can often go home the same day or even the next day. Unfortunately, patients with very severe achalasia, so-called end-stage achalasia, when there's almost no treatment we can do and almost nothing more we can offer, these patients we'd actually recommend an esophagectomy where we actually surgically remove the esophagus. And the last treatment modality is BOTOX, and this is similar to the BOTOX that we may do for cosmetic procedures, but we use it in much higher doses. Unfortunately, BOTOX is temporary. If it works, it will work for about 3 to 6 months. So patients might have to come back 3 to 6 months later to get another treatment. Or we might suggest that the patient goes for a more definitive procedure, something that lasts much longer and is more durable. This is how we do BOTOX endoscopically. The catheter goes down the needle. We inject BOTOX in the lower esophageal sphincter. We know that BOTOX relaxes the muscle, and this can relieve the dysphagia, albeit sometime temporarily. And the final test that we can do for patients with esophageal dysphagia is the endoflip. This is the new kid on the block. It is similar to esophageal manometry. The two main differences are, number one, we do it under sedation, so the patient is completely asleep, and we pass it through an endoscope. And number two, instead of measuring pressure like we measure with manometry, we measure distensibility. And what distensibility is how compliant the esophagus is. And based on this compliance, we get these beautiful images, and we can use endoflip to diagnose other causes of dysphagia. So in summary, and I know I've said a lot, and I hope you found this morning useful, but my take-home points on this webinar on esophageal dysphagia: please take all dysphagia seriously. Don't let any cause of dysphagia go undiagnosed. We often term dysphagia as an alarm symptom. We want this to be taken seriously, and we should make a diagnosis. History taking is the most important. Please, your gastroenterologist should spend as much time needed to take a good history to try to identify which kind of dysphagia we are dealing with. We wanted to separate dysphagia into two main groups: esophageal dysphagia, and the first test that we do is a modified Barium Swallow. The second main group we want to identify is esophageal dysphagia, and we could do one or some of these tests. And finally, the treatment of dysphagia really depends on the cause. So I want to thank you for your time this morning. It's been a great pleasure spending time with you. During this talk, we've had some questions come to us through social media, and I think we have time for some questions. Thank you. So the first question is, which test do you do first, an upper endoscopy or a barium swallow? And the answer, as it is in most aspects of medicine, is it depends. So if a patient has oropharyngeal dysphagia, I do a modified barium swallow first before an upper endoscopy. If I think the patient has esophageal dysphagia, that's where it really depends. If I think the narrowing is really severe, then I'd send the patient for a barium swallow first. The reason I do a barium swallow first is the barium swallow gives me a roadmap. It kind of lays out the anatomy so that when I do the upper endoscopy, I have no surprises, and I can have all the tools in the room that I may need based on what the barium swallow showed me. So if I'm suspecting a severe narrowing of the esophagus, I'd get a barium swallow first, followed by an upper endoscope. Second question that was asked. Once a stricture is dilated, will it come back? And the answer to this is sometimes it may come back. And how would we know it's coming back? Is the patient would have ongoing symptoms of dysphagia. And what we could do is we could bring the patient 2 or 4 weeks later to repeat dilation. This time we'd use a larger balloon with a larger diameter, and we'd try to stretch the stricture a bit more. Certain strictures, despite dilations, we really don't get them better, and in those patients we might inject steroids to help decrease some of the scar tissue. And then the final question is, what happens if all the tests come back negative and the patient still has dysphagia? And as I mentioned in my talk, we call this functional dysphagia. It's very unusual. We normally see it less than 5% of time. We can often offer the patients reassurance. We can sometimes refer for CBT, which is cognitive behavioral therapy. We sometimes try, medications. We have nothing to lose, so sometimes we'll try BOTOX, we'll try dilations, and most times, patients will feel at least some improvement in their symptoms. So those are all the questions we have time for. Once again, thank you so much for spending time with me this morning. I hope this was very informative, and please reach out to me, contact me at my office, and I'd be happy to see you. Thank you.